Skin cancers are broadly categorized into two types, melanoma and non-melanoma. We will study melanoma in our next video. Today we will be learning about the epidemiology of non-melanoma cancers, their genetics and factors, pathophysiology, clinical presentation, prevention, and treatment.
We'll look at exactly how these cancers form, we'll see how they look on the surface, and we'll review the exact treatments for the three main types. These are basal cell carcinoma, squamous cell carcinoma, and Merkel cell carcinoma. Over 5.3 million. That's the number of new non-melanoma skin cancer cases every single year, just in the United States. The sheer scale of this is profound. Most of these cases are basal and squamous cell carcinomas, but there's another type called Merkel cell carcinoma. It's much rarer but highly aggressive, and its incidence has actually tripled over the last 20 years. We really need to thoroughly understand these cancers to effectively. Let's find out exactly where in the skin these cancers actually begin. Your skin has distinct layers. These cancers originate in very different geographic locations within those layers. Basal cell carcinoma, or BCC, starts in the basal layer. This is the very deepest part of the epidermis. Squamous cell carcinoma, or SCC, starts higher up. It begins in the squamous cells of the upper epidermis. Finally, we have Merkel cell carcinoma, or MCC. This one starts much deeper, right near the junction where the epidermis meets the dermis. It specifically involves the Merkel cells. These are unique neuroendocrine cells that are actually related to your sense of touch. So each cancer has a very distinct physical starting point. So what causes these cells to become cancerous? Ultraviolet radiation is the most significant driving factor. The risk is incredibly direct. For example, just 4 visits to a tanning bed in a single year increases your risk of BCC by 15%. It increases your risk of SCC by 11%. But there's another major factor. Chronic immunosuppression acts as a massive risk multiplier. If a patient receives a solid organ transplant, they need medications that suppress their immune system. For these patients, the base risk for BCC is multiplied by 10, and the risk for SCC skyrockets to an astonishing 65 times the normal rate. There are a few secondary drivers too. These include HIV infection, ionizing radiation, chronic ulcerations, and thermal burn scars. Let's look at the specific genetic mechanics of basal cell carcinoma. It relies on something called the hedgehog signaling pathway. Normally, your body has a tumor suppressor gene called PTCH1. Think of it like a brake. It stops cells from dividing out of control. It does this by blocking a specific protein called SMO. But sometimes, a mutation breaks this PTCH1 gene. Without that break, the SMO protein is completely uninhibited. It pathologically activates the hedgehog pathway. This directly drives the development of basal cell carcinoma. It's also important to mention Gorlin syndrome. This is an inherited condition where patients are born with these PTCH1 mutations. Because they lack that genetic break from birth, they are highly predisposed to developing multiple BCCs throughout their life. All of this genetic activity beneath the surface leads to very distinct clinical appearances on your skin. The outward look of BCC varies significantly based on its specific histologic subtype. It primarily presents in 3 different forms, or morphologies. These are nodular, superficial, and morpheoform. Each one looks very different to the naked eye. Let's break those down. The nodular subtype is the most common. It usually presents as a shiny, pearly nodule. It has rolled borders, and you can often see tiny twisted blood vessels on the surface. These are called telangiectasia. Next is the superficial subtype. This one looks like a red scaling plaque. It can be tricky because it easily mimics common harmless skin conditions like eczema or psoriasis. Finally, we have the infiltrative or morpheoform subtype. This one is highly aggressive. It looks a lot like a flat, yellowish or white scar. The borders are indistinct and hard to see. It's particularly dangerous because it often hides its true size deep beneath the surface of the skin. Now, squamous and Merkel cell carcinomas have entirely different genetic drivers than BCC. Let's look at squamous cell carcinoma first. SCC is primarily driven by direct ultraviolet damage. The UV light damages a crucial tumor suppressor gene called p53. This gene normally protects your cells. The UV light also mutates an oncogene called NRAS. This actively drives abnormal cancerous cell growth. Merkel cell carcinoma, on the other hand, is completely different. It's largely driven by a virus. In roughly 80% of MCC tumors, the Merkel cell poliovirus is present. This virus produces a specific antigen. That antigen actively attacks and shuts down your body's natural tumor suppressor pathways. Let's focus on how squamous cell carcinoma develops over time. It evolves along a continuous progression spectrum. It moves smoothly from a simple pre-malignant lesion into a fully invasive cancer. When medical professionals use a special magnifying tool called a dermatoscope, they look for a specific visual hallmark. To identify invasive SCC, they look for the distinct presence of dotted or coiled blood vessels right on the surface of the lesion. This progression spectrum usually begins with something called actinic keratosis, or AK. This is a rough, sandpaper-like bump found on heavily sun-damaged skin. It's not cancer yet, but it can turn into it. If it progresses into invasive SCC, it typically transforms into an ulcerated, bleeding red nodule or a firm bump. There's also a closely related form called keratoacanthoma. This is a low-grade variant of SCC. It grows very, very rapidly. It forms a distinct, dome-shaped bump with a very noticeable crater right in the center. Moving back to Merkel cell carcinoma. Because it's so rare, doctors need a way to reliably identify it. They use a simple profiling tool called the AIOU criteria to evaluate rapidly expanding skin nodules. A stands for asymptomatic. This means the nodule does not hurt, which is surprisingly dangerous. E is for expanding rapidly. I is for immune suppression. O is for older than 50. And U indicates a UV-exposed site, meaning it appears on sun-damaged skin. The most crucial thing to understand about Merkel cell carcinoma is its deceptive danger. This is a rare, highly aggressive neuroendocrine cancer, but because it presents as a completely painless, flesh-colored, red or blue nodule, patients often just ignore it. They think it's harmless. A rapidly growing nodule on your skin should never be ignored. This is especially true considering that the incidence of this specific, deadly cancer has tripled over the last 20 years. Early detection is absolutely vital. Prevention is all about stopping cumulative damage to your skin. We approach this in escalating tiers. The very foundation relies on simple behavioral changes. This means active sun avoidance and wearing protective clothing. Moving one step up the pyramid, we have topical sunscreens. These are highly effective at preventing pre-malignant lesions like those rough actinic keratoses we discussed earlier. Finally, for patients at the very highest risk, doctors use pharmacological interventions. This is known as chemophilaxis. Doctors prescribe synthetic medications like oral retinoids. These actively help control the development of new cancerous lesions from forming. Sometimes a patient has a large area of extensive sun damage. In these cases, physicians utilize field therapy interventions. Instead of just treating a single spot, topical creams or gels are applied to an entire broad grid of skin. The goal is to prevent any hidden abnormal cells from progressing into invasive SCC. We use agents like 5-fluorouracil, imiquinod, and ingenol mubitate. When a localized tumor does develop, we have to carefully remove it. The choice of treatment depends heavily on the tumor's location, its depth, and how likely it is to come back. Standard local options include scraping and burning, which is called electrocitaskation and curettage. We also use standard surgical excision, freezing with cryosurgery, or targeted radiation. However, There is an advanced technique called Mohs micrographic surgery. Mohs provides the absolute highest cure rates, exceeding 98%. During a Mohs procedure, the surgeon immediately checks the microscopic edges of the removed tissue while the patient waits. Because it preserves healthy skin and guarantees the cancer is gone, Mohs is strictly preferred for recurrent tumors and cosmetically sensitive areas, like the face. Treating Merkel cell carcinoma is very different. It requires a much more aggressive, multi-step surgical protocol to make sure the cancer hasn't spread. Step 1 is a wide local excision. The surgeon removes the primary tumor along with a very large margin of surrounding healthy-looking tissue. Step 2 is a sentinel lymph node biopsy. This step is absolutely crucial. The surgeon checks the very nearest lymph nodes to see if microscopic cancer cells have begun to travel away from the primary site. Finally, step 3 involves adjuvant radiation. Radiation is applied to the area after the surgery. This deliberately destroys any lingering invisible cancer cells to prevent the tumor from returning. Sometimes the disease becomes advanced or inoperable. In the past, this was devastating. But today, medical science turns to advanced systemic interventions. We use targeted inhibitors and groundbreaking immunotherapies. These actually help the patient's own immune system fight the cancer. For advanced basal cell carcinoma, we use oral SMO inhibitors, like vismodegib. Remember that broken hedgehog pathway we talked about? This drug directly blocks it. For advanced squamous cell carcinoma, we utilize an incredible immunotherapy called semiplimab. And for metastatic Merkel cell carcinoma, the immunotherapy avelumab has largely replaced traditional harsh chemotherapy. It provides highly durable and effective responses for a significant portion of patients. So everything we've discussed today connects together into a unified clinical continuum. We can successfully trace each of these 3 cancers from their microscopic origin all the way to their advanced treatment. Basal cell carcinoma is driven by the hedgehog mutation. It presents as a pearly nodule and is treated systemically with SMO inhibitors. Squamous cell carcinoma is driven by UV damage. It presents as an ulcerated nodule and is treated with semiplimab. And Merkel cell carcinoma is driven by a viral infection. It's identified by the AIOU criteria and is treated with avelumab.